So my name is Dr. Satwant. I am one of the fellows currently getting trained in interventional radiology, and we are lucky to have with us Dr. Ram Gurajala. He's a staff. He's a practicing IR for last many years with lots of experience, and today we are lucky that he has given us this opportunity, his valuable time to talk about the changing perspective in the management of the various hepatic tumors. So I would like to welcome Dr. Ram to a brief discussion. So to start with, sir, in your experience for the last over maybe 10 to 15 years, how has the management of hepatic tumors evolved over the time, and where does the IR currently stand in that management?
Firstly, thank you, Dr. Satwant, and my name is Ram Gurajala. I've been practicing interventional radiology for many years now. That's a good question to start with. There's a broad spectrum for this question to be answered. If we go back a decade back, so people used to consider tumors means they are not curable, surgery might be the only option, or maybe radiation or chemotherapy. Interventional radiology was never thought to be a fourth pillar. That's what we call it. It's considered to be a fourth pillar in oncological management. So what it means is we are equally important in par with the surgery, with a radiation oncologist and also an oncologist. So coming to the interventional radiology treatments, so almost like I said, decade back, the only treatments that were offered in interventional radiology were ablation, where the tumors were killed by applying thermal energy or non-thermal injury. The second one was by doing something called chemoembolization, so where we put a catheter into the liver and check the blood flow to the tumors and put beads which are having like a chemotherapeutic agents. So it is a conventional chemoembolization where we used to use a contrast agent called lipoidal. Then the trends, I think we advanced to a certain extent. So instead of lipoidal, we started using a drug eluting beads, we call them, where the beads are coated with doxorubicin chemotherapeutic agent, or something called irinorectin, which is used for colorectal mets. So that's over the years. So then the more advanced version, if you can think of some treatment that we can offer, is called radioembolization. So here, instead of the chemotherapeutic agents, what we do is we use the radiation particles. They are connected to a radioisotope. We inject them into the liver, into the blood supply, supplying the tumor. And this killed by radiation effect. So now, if you look back at all of these ones, there are certain guidelines for interventional oncology. Everything is included in the guidelines, but unfortunately, radioembolization is still at the early stage to be included in the guidelines. So we have, we can say there's a master chef cook system. That's what I call as interventional radiology. One treatment is not pertaining to one patient. So we can have different options, combination options, because the intent should be a curative, like a surgery, in majority of these cases.
Thank you, sir, for the elaborative answer. So just carrying forward, so let's just first we can start with the basic and then we can go to the more complicated things. So right now we are just focusing this talk on hepatic tumors. So what are the different types of malignancies that are amenable to the interventional treatments for the tumor? I mean, can it just be the primary hepatic cellular tumors, or are we offering something else, our services for other tumors as well, which maybe metastasize to the liver, or invade them or something like that?
So in one word, we can offer our services to all those tumors which are confined to the liver. If they are extra hepatic, that means which are outside the liver, we have to be cautious how far should we offer our services. So like Dr. Satwant said, we can divide these tumors into primary and secondary. So primary are those cancers which are confined, which are primary in the liver. They originated from the liver. For example, the most commonest is the hepatocellular carcinoma. The second comes the cholangiocarcinoma. If you take the secondary liver cancers, which are not the primary in the liver, which are spread from somewhere else, and they are residing in the liver presently, and the most commonest you come across is the colorectal metastasis. Then you have neuroendocrine mets, they have breast metastasis. So there are other non-liver-based tumors which can metastasize to the liver. So every tumor has got a different way of acting, and likewise the IR treatments are like a different for different types of these tumors.
Yeah. So this brings to my next question. Like as we discussed that Y90 or the radioembolization for the liver tumors is an upcoming thing with people are doing it for different reasons and they're getting good results out of it. But I think for a layman, like what kind of radiation is it? Like what's the systemic effects? I mean, if a person is getting treated with Y90, does he need to live separately for a certain period of time, or like is there any precautions, or it's just limited to the liver? I mean, how does it work?
Okay, I think that's a very good question to ask, because most of the people who come across this procedure are laypersons. They do not understand the real meaning of this radioembolization. So if you can start, this is particles which carry radiation with them. Instead of giving radiation from outside the body, we are giving radiation inside the body at very close to the tumor. So our goal is to kill the tumor to the maximum effect, at the same time spare the normal part of the liver so that the patient does not have any liver failure. So in particular to the procedure, it's done in different stages. So first stage, what we call as a planning angiogram, where we map all the blood vessels supplying this tumor, and we'll try to make as closer to the tumor as possible. During this planning angiogram, we inject some fake beads. This is to understand the perfusion part of the tumor. At the same time, we also need to know how much shunting is happening to the lungs or the surrounding tissues, because we want to calculate the lung shunt to see how much of the radiation is affecting the lungs. Based on the guidelines, there is a limit, like how much radiation you can use based on the lung shunt fraction. For example, about 10%, sometimes we have to confine your treatment to very close to the tumor, or you have to say this is not the best treatment. Once the procedure is done, like Dr. Satwant was asking, what is the effect after the procedure? So the comparison to the radioembolization, the closest one you can think of is called chemoembolization. So chemoembolization, where the beads are loaded with chemotherapeutic drugs, they have a toxic effect after the procedure, where they release the toxins and they can cause pain, they can cause vomiting, and they can cause other like a fever, and their decrease in their activity, day-to-day activities for next few days to weeks. That's called post-embolization syndrome. When it comes to this radioembolization, surprisingly, we don't see that very often at all, because here, after the post-radioembolization, people will feel tired rather than having pain. This tiredness is because of a radiation effect, because it's killing the cells, and that's very temporary. And if you see people, most of the people regain their normal energies, and they go back to the day-to-day activities within the next few days, or at the most in 1 to 2 weeks time. And there's no long-term side effects for the radioembolization aside from the effects at the time of the procedure, that for which the operator has to be very careful. The disadvantage only I could think of radioembolization is if you're not careful and if you overdose the radiation, there is a chance that liver can be failed, and the patient might develop something called ascites, which is free fluid in the abdomen, or the liver can fail and does not function to the normal function. So we have to be careful in planning and in delivering the dose.
Okay, so in a nutshell, as we started that initially open surgery, then came the laparoscopic ones, then from the laparoscopy people went to single port surgeries, and I think from single port the things are going towards more minimal invasive, which is the IR. So as Dr. Ram has elaborately discussed, that we have many options. I mean, 10 to 12 years before, people having liver metastasis, stage 4 malignancies, we could hardly offer anything. But today we have like many options from which the patients can choose, and we can also select an appropriate patient with like new treatments with Y90 with minimum systemic toxicities emerging up. I think the future of IR in management of hepatic tumors is gonna be great. Well, thank you, Dr. Ram, for the very elaborative information. So I would like to end this session now. Thank you so much for listening to us, and stay tuned for more. Thank you.